got one more before you get to sit down again. So Jody is going to lead us in Oh, What a Night.
So a little slower, a little more work on strength and balance. So, do what you feel comfortable with. We're starting just a lot.
Oh, what a night. Late December back in '63. What a very special time for me. As I remember what a night. Oh, what a night. You know I didn't even know her name, but I was never gonna be the same. What a lady, what a night. I got a funny feeling when she walked in the room. As I recall, it ended much too soon. What a night. Hypnotizing, mesmerizing me. She was everything I dreamed she'd be. Sweet surrender, what a night. I felt the rush like a rolling ball of thunder, spinning my head around and taking my body under. What a night.
All right, hello everyone. Oh God, the light. So, well, thank you all for coming. This is the last talk. I'm gonna talk about deep brain stimulation and focused ultrasound. Well, I'm really glad that they did the movement session because my talk might be a little too technical, a little too boring. So they probably said, oh, Dr. Situ is the last one, so might as well shove that in. Anyway, for those who don't know me, I'm Miguel Situ. I'm one of the assistant professors for movement disorders. And I've been here for 3.5 years, and so far I'm liking it, so that's why I'm staying longer. In any case, I do most of the evaluations for deep brain stimulation while the patient is in surgery. And of course, I'll be talking about that. So let's get started. I have no disclosures. Anyway, so when should deep brain stimulation and focused ultrasound and advanced therapies for that matter be discussed? They should be discussed since the first visit because it's something important for you to know. It keeps patients informed about their options, saying that medications are not the end. There's other things that we can do. Exercise is always important. I think I say that in every single visit. It emphasizes shared decision-making because I think this is something that we shouldn't impose upon you. This is something that you guys should know and should say, okay, is this the right treatment for me, or do I want something else? And then it also allows for future planning because deep brain stimulation will change your quality of life. So before going into, and I'm talking a lot about deep brain stimulation because that's the thing I do, but of course I'll talk about focused ultrasound, but what parts of the brain are we targeting with both procedures? So I don't know how much you look into your own information, but we do target several targets. One of them, and the most common one that we do for Parkinson's disease, is the first one. So the subthalamic nucleus, or STN. So if you see in your chart STN a lot, that's what it means. Globus pallidus pars interna, or GPI. We tend to use that too for Parkinson's disease, though sometimes we also use it for other conditions in movement disorders such as dystonias. And then the last one, which is the ventral inferomedial thalamus, or the ventral inferomedial nucleus of the thalamus, which is an older target. Actually, if I recall well, Michael J. Fox has VIM stimulation, which is one of the oldest targets that was used to control tremor, but the problem is that it doesn't help with other symptoms of Parkinson's disease. And so what are the advantages of it? The subthalamic nucleus, again, helps with most Parkinson's disease symptoms, motor symptoms at least. It can decrease your levodopa dose. So for instance, if you're taking 4 tablets 4 times a day, it might actually reduce it to 2 tablets 4 times a day, or 2 tablets 3 times a day. I always say each patient is different, so there will be a spectrum of how much benefit you get. I put it as an example. I have a patient who uses no levodopa after surgery. And other patients, they still need quite a bit of levodopa after it. And it also improves motor fluctuations. So that means that those fluctuations that you have when you're on your medication and all of a sudden you go off and then you feel frozen or you feel rigid. Constant stimulation potentially gives you the benefit of not having that as often. With globus pallidus pars interna, the benefits are quite the same. In GPI, it tends to not have as much of a decrease in the burden of medication as STN. However, in some cases it does. I mean, if you look at it this way, if you're needing medication so much because you're having a lot of fluctuations, if you have loss of those fluctuations because you're getting constant stimulation, yeah, you might decrease your medication burden too. It improves dystonia symptoms, so patients who have significant dystonia or abnormal contraction of the body whenever they are having their Parkinson's symptoms, GPI might be a better target. And then there's the added benefit for less programming sessions in the case of deep brain stimulation. especially patients who live too far away, GPI might be a target. And finally, well, VIM, as I said, it improves tremor. There's less chance of causing psychiatric or decompensated psychiatric conditions, but the problem is that it doesn't really help with other symptoms of Parkinson's disease. So this is a little bit of a diagram so you know where we're drilling into your brain. I mean, yes, the brain is a little complicated. I wish we had an actual 3D image of it, but if you see the pink nucleus, that's below the GPI, so that's more or less where the STN would start going. Or sorry, the green one. The pink one is where VIM is or GPI might be, and the thalamus is on the brown one right above. So we'll go ahead with deep brain stimulation. So I'm pretty sure a good portion of people who are present here, someone may have already have the surgery. Do you mind raising your hands up if you have DBS of any shape or form? Yeah, there are a few quite there. So I would ask people before I go into this information to actually talk to them. I mean, don't accost them, but at least talk to them, because the real experts are actually the patients who have experienced the surgery, because each patient will be different, and each will have its own course, its own journey, its own experience. So, I mean, what we give you is information, but the real experience is from the patients. The second people I would ask would be the case managers who are like out in the back. They are the ones who do most of the work in programming, in making sure that our patients are optimized. So talking to patients, talking to our case managers, those are the ones that will give you the most information about what individualized benefits you can get from DBS. We, the doctors, we just give information. We have the MDs, and we pretend to know more than everyone else. But anyway, so what's deep brain stimulation? So it's a surgical procedure. We implant electrodes into specific targets of the brain, and we push low voltages, low current, and then we expect to get some symptomatic benefit from it. I want to highlight that it is not a cure. So deep brain stimulation helps with your symptoms, but you will always still have Parkinson's disease. That is something important I want to emphasize, because there are some patients who say, oh, so that means I will no longer need medications forever, and then I'm good to go. And that's, unfortunately, we wish that were true, but it's not real. You will still have Parkinson's. The Parkinson's will still progress. It will not slow down the disease. It will improve your quality of life, but the disease is still going to be present. So that's something for you to be aware about. And that's also important, because whenever we ask or we determine candidacy for deep brain stimulation, we ask our patients, what is the expectations? And we want to make sure that we set up real expectations. If the expectation is going to be, I don't want to have Parkinson's disease anymore, unfortunately, we will not be able to comply with that. So how do we evaluate for candidacy? So first of all, we discuss the interest with the patient. So the process starts in our office visit. And again, ideally, in the first office visit, I have to admit that sometimes I do forget, so that's my fault. So if you're a first-timer with me, make sure to ask me about DBS. But yes, we discuss candidacy the first time with the patient. We tell them, okay, this is what the process is involved, what we do, what we expect. And then we ask the patient, okay, what are your thoughts about it? Or do you want to proceed with this? Remember, this is an elective therapy. This is not something that you necessarily have to do. There's other alternatives too. And then, well, if the patient is in agreement with it, then we schedule something called an on-off testing. Here at UNMC, we do it inpatient. However, for those folks that have had deep brain stimulation surgery done elsewhere, some other institutions do it outpatient, so in the clinic setting. So that's not a general rule in the US. What does the on and off testing get involved? Basically, we test you when you're off your medications and then when you're on your medications, and I'll detail that more later. Then afterwards, we schedule a brain MRI with specific sequences. These sequences will allow us to find the target correctly and be able to say if there's any abnormalities that we need to address before going into a surgery. We also do perform a neuropsychological evaluation, so we put a referral to our neuropsychologist because we want to make sure that we have a baseline cognitive test on you. Remember, at the end of the day, it's still brain surgery, so there's still things that we can affect in the brain. And finally, once we have all of those steps, then neurologists, neurosurgeons, neuropsychologists, our case managers, our trainees, they all get together. We have a multidisciplinary conference and we discuss the case in detail because we want to make sure that you are the appropriate candidate and that you will have the best outcome possible. Oh, and this is repeating. Okay. Anyway, so a little more detail into what is the inpatient on and off testing. So when you get admitted, and that's something I didn't mention, well, before you get admitted, actually, you get the neuropsychological testing. And then afterwards, you get into the hospital. You will take your medications in the evening, but then, well, and that depends on the patient, but usually a rule is you get your last dose in the afternoon or the evening. Sometimes, in some cases, if they we want to get a better effect, we tell them to stop medications all day or all day prior to the actual test. And then you stay in the hospital overnight, and then in the morning, there's going to be an evaluation of your motor symptoms through our case managers. So same thing as we do when we're in the office visit, that MDS UPDRS, where we make you do your finger tap, your flapping your hands, moving your feet, make you walk. Same thing, our case managers are going to do it while you're off all medications. Because we want to make sure that we see you at your worst. I know it sounds bad, but we want to make sure that we see that there's going to be a good response from the medication. So afterwards, we give you not 1 time your dose, but 1.5 times and even 2 times your dose, because we want to get the maximum benefit possible of the response to levodopa and then evaluate you in spite of your side effects. And the reason is because, first of all, we want to prove to our neurosurgeon saying, like, yes, this patient is going to be a great candidate because he has a great response to the medication. Because the DBS, or the deep brain stimulation, will help with all the symptoms where the medication has been helping. It will not help with the symptoms that the medication doesn't help with. So for instance, if you have severe freezing of gait, and despite you being on, let's say, 5 or even 6 tablets of levodopa, you still have freezing of gait, there is a high chance that even with deep brain stimulation, you will unfortunately still have deep freezing of gait. So again, we test you while you're off, then we test you while you're on, and then afterwards, before you're being discharged, usually we either put a schedule for a brain MRI before you leave, or if there is no schedule available, then you'll get a brain MRI at a later date. And I don't know why this is repeating. So how to know if it's right for you? Again, as I mentioned, if you have an excellent response to Parkinson's disease medications, if you have, in spite of having good response, you have intolerable side effects. So for instance, if the medication, you take 3 tablets and you feel great for a little bit, but then you start developing nausea, vomiting, bothersome dyskinesias, or other side effects, but it still gives you good motor response, then that's another reason to think about DBS. If you are on a high dose burden, so if you're taking a lot of pills, so back in the day when we still were investigating about deep brain stimulation, we're talking 90s or early 2000s, there were patients who were on 30 tablets, 40 tablets, 50 tablets. I think the highest dose I've ever seen had been a patient where I was a trainee who was taking 68 tablets of levodopa. So That's a lot. And then if you have unbearable motor fluctuation, so in spite of taking that medication so often, again, there's patients who take medication every 90 minutes or every 2 hours, and in spite of doing that, you still have severe offs. So for instance, you tell me, I take my medication, it lasts 20 minutes, and then 20 minutes later, I feel off again. I think there's an extreme case of a Dr. Smith patient who has an on of just 2 or 3 minutes before feeling off again. So again, that's another extreme case, and that's another reason where deep brain stimulation might be a good alternative. How to know if it's not right for you? So again, deep brain stimulation has its caveats. First of all, it's a surgery. So surgical high risk, and that's something that the neurosurgeon might give you more details about. If you have a decompensated psychiatric condition, because again, as I mentioned, it's still brain surgery, still can affect your ability to think, it can still affect your mood, and part of the surgery is done while you're awake. So that's something that we need to make sure before we put you on the table. If you have a structural brain lesion, so for instance, if you have a tumor, if you have a significant stroke, for instance, if you have a stroke in the place where we're putting the leads, then DBS might not be a good therapy because we would essentially be putting the electrode in dead tissue. So that might not give you the benefit that you'd like. And again, and this is a relative contraindication, severe dementia. Now, here in the US, we're a little more strict with how we select our patients, but there has been studies in Europe, especially in the UK and Belgium, where they've implanted deep brain stimulation even in patients with moderate and severe dementia, with the argument that yes, it still will give them good quality of life, right? If they're demented, but at least they are able to move better, sure, if that helps them. But on the flip side, if they're demented and agitated, and we make them move better, they might actually be more agitated and more violent. So that's something that we have to take into consideration. I will not detail anything about the surgery because that's something that neurosurgeons should have better information. Just of note, we have 2 wonderful surgeons, neurosurgeons that do deep brain stimulation here at UNMC. Some of you guys may already heard about them. So Dr. Avesillas and Dr. Abosh are our 2 functional neurosurgeons. They each have their own style on how they do the surgery. Dr. Avesillas does it through imaging guidance, so it requires as a phase where you're asleep and then you're awake and then asleep again, while Dr. Abosh keeps you awake in the beginning and then puts you to sleep afterwards. Either method really works, and there has been no significant difference, at least from studies on awake surgery or a sleep surgery or partially asleep surgery, on whether one methodology is better than the other one. But again, that's for either neurosurgeon to give you a more detailed explanation on the surgery itself. So after the surgery, what's next? So afterwards, after we allow the brain to heal, after you have the batteries, then you'll have an initial programming session that may take several hours. And this is done through our case managers, who they've had ample experience with it, and they will put you one morning and spend a lot of time with you, making sure that we get the good settings and good initial benefit. Sometimes it may require more than one session, so do not fret if in the first session you feel that, oh, I'm not getting the response that I was promised. It might sometimes take a little longer. And then subsequent sessions to fine-tune the appropriate response. And as I mentioned, Parkinson still moves on, so every now and then you will still need some kind of adjustments. Now, will medications be stopped? Realistically, medications will always be needed, though the burden may decrease. In theory, yes, when DBS first came up, the objective was to make sure that patients would be off completely levodopa, but we know now that that's not the case. And remember, each patient is different. So again, your journey may not be the same journey as your neighbor or your friend with Parkinson's disease. So that's about deep brain stimulation, and that's the one we have more information about because at UNMC we do that procedure. Focused ultrasound is a different procedure. It's a different thing, and it's a non-surgical technique. Basically, it's an MRI-guided process where high-frequency waves create a lesion in a specific target of the brain that provides symptomatic benefit. So again, it is not a cure. Same thing as DBS, it's only to treat symptoms. I want to highlight this. This is still being researched for Parkinson's disease, so it's not something that we do or it's done on a regular basis. UNMC currently does not perform the procedure. We don't have anybody who's doing that. So you would probably be referred to an outside facility. To my knowledge, CHI was doing focused ultrasound, but they do it mostly for essential tremor. I am not sure if they are actively doing it for Parkinson's disease. The closest center that I know that have been doing focused ultrasound on a frequent basis for Parkinson's disease, even though it's still for research purposes, is at Rush University in Chicago. How to know if it's right for you? Same indications as DBS, but if you say, well, I don't want to pursue invasive surgery, again, if you have an excellent response to PD medications, if you have side effects, if you have high dose burdens and motor fluctuations, then focused ultrasound may be a choice. Now, procedural high risk there's still, I mean, even though it's non-surgical, it's still a procedure, and there is still gonna be some kind of sedation because they wanna make sure the surgeon who performs this wants to make sure that you remain as still as possible so he can accurately target whichever part of the brain he needs to. Again, structural brain lesions where intended targets are, same thing. And if you're unable to have an MRI, because this procedure requires MRI guidance to do it. So if you, let's say, you have a lot of metal in your skull, or if you have a defibrillator or some other device that cannot be turned off, then this procedure might not necessarily be the one for you. Now, if we compare focused ultrasound to deep brain stimulation, again, as I mentioned, it's a non-invasive procedure. There's no hardware implanted, and you can leave on the same day because, again, there's no cuts, there's nothing. You just rest for a couple of hours, and then you could go home. However, it is a completely reversible process because what it does, when it targets that part of the brain, it creates a hole in it. And again, you cannot reconstruct the brain once it's destroyed. So it's irreversible. If it doesn't work, it doesn't work. And then some of these patients may need to go to either deep brain stimulation or opt for other kind of therapies. It cannot be readjusted. It's not like, oh, I accidentally made a hole in the brain. Let's put some Play-Doh on it and put a hole somewhere else. And still, unilateral procedure has been done for most cases. And this applied more for patients who had focused ultrasound for essential tremor, where they found that patients were having speech problems. In the cases of deep brain stimulation focused ultrasound for Parkinson's disease, there's been some issues with mood, but again, it's something that is still being explored. Now with newer techniques, it might be more accurate, so there might be better outcomes. And of course, because it's still being studied, it has undetermined long-term benefits. We still do not know how good this procedure would perform against deep brain stimulation. Remember, deep brain stimulation has been clinically applied in the United States since at least 1997, so we have at least 25, 26 years of it, while focused ultrasound has been going off and on, and there's really haven't been any large population studies about it. I can tell you there's patients who have had focused ultrasounds in the sense that they had strokes in the areas that cause Parkinson's disease, and luckily, they actually get better from it. So that's one of the logics of doing focus ultrasound. But anyway, so that's about it for DBS and focus ultrasound, and we'll answer your questions later. Thank you.